Autism Canada depends on the generous support of viewers like you. If you find this presentation helpful, consider donating at autismcanada.org.
So it's a pleasure to be able to talk about apraxia, which I believe is a very common but often overlooked comorbidity in autism spectrum disorders, and I hope by the end of this talk you will also believe that that's true. So how many folks in the audience actually know what apraxia is? If you could raise your hands. So that's good, more than probably my medical colleagues. How many of you actually have a child who has apraxia or dyspraxia? Okay, and then how many are taking care of children in your clinic? So we're going to go over a few definitions to provide a little bit more clarity, and then after that I'll get into some, what's considered alternative therapies that seem to have worked at least for a cohort of children. And I'm going to be presenting data from my original cohort that I published, but since then I've had dozens of families who have provided more information, and it's all anecdotal, but the numbers are just accumulating, the kids who have this syndrome and these nutritional deficiencies that are benefiting from interventions like diet, fish oil, and vitamin E. So just to start from the beginning, communication disorders, and a lot of my information is based on the United States, but I would imagine that percentages are similar in Canada, even if some of our strategies are a little different. But the communication disorder is the #1 developmental disorder in children under age 5. 80% of all early intervention cases involve speech and language, and communication disorders cost the United States over $30 billion a year in lost productivity, special education, medical needs, not to mention all the heartache that goes with it. And 20% of late talkers will have a true speech and language disorder. So the well-meaning pediatrician who reassures you that this is just going to get better is really doing you a disservice in the sense that this delay translates to missed opportunity for early intervention for those late talkers. And in the United States, at least, that delay also translates to increased expense to the family because under age 3, all these assessments are free and your intervention is free, and anyone who actually gets speech therapy for their kids knows how expensive it is. So anything you can get provided for you when you're starting off and still digesting these diagnoses is healthy and important. So apraxia and dyspraxia comes from the Greek root of praxis, which means activity engaged in by free men. So Aristotle described good praxis versus bad praxis, and dyspraxia actually translates to misfortune, which is actually a perfect word for this disorder and what it brings to the families who end up with this diagnosis, particularly since there's so much misinformation and lack of information in the medical community. So part of this confusion leads to the fact that we're not even talking about, using the same name. There's so many different terms that are used for apraxia. I will use the term verbal apraxia, but the term that's accepted by ASHA, the American Speech, Language, and Hearing Society, is childhood apraxia of speech, which is also inappropriate because these children grow up to be adults with childhood apraxia of speech. What do you call them then? So we'll run through some of these definitions. So dyspraxia is sort of the big group term name, and it's a neurogenic impairment that involves the planning, executing, and sequencing of motor movements. So the etiology is currently unknown, but it's likely multifactorial. Now, verbal apraxia, that's the apraxia that affects the speech. Still not? Oh, no, I'm good.
No, it's not going up on the screen.
Oh. Sorry about that. Okay, I'm going to have to look over there then. So verbal apraxia affects the programming of the articulators to perform rapid sequences of muscle movements in order to produce speech sounds. Now, oral apraxia is often seen with verbal apraxia, but is different. So it involves the non-speech movements, so the puckering, the blowing of bubbles, the kiss, So you see these kids at age 2, they can't blow out their candles like other kids. They can't blow bubbles like other children. That's oral apraxia, often seen with verbal apraxia, but still different. And this was a whole new language for me as an ER doctor, receptive language, expressive language, it was all the same thing until I learned more. Limb or motor apraxia. So this involves the programming of hand and whole body movements, and it also suffers an identity crisis because of the so many names used for it. So developmental coordination disorder, or the one I like least, clumsy child syndrome, or dyspraxia. So usually when someone says dyspraxia, they're talking about the motor movements. And what's interesting is I've yet to meet a child or talk to a family with a child who has verbal apraxia who doesn't have more than that. But very often they'll say, no, there's no dyspraxia. And as they get older, it's like, well, can they tie their shoes? No. Can they ride a bike? No. So these are signs of coordination issues that we often don't realize because it doesn't get picked up until school age, where tying your shoes and riding a bike, all of a sudden you realize that this child is a little bit different. Because when toddlers are falling down, kids fall down, right? But maybe these children fall down a little bit more than usual. And if you look at the literature, the dyspraxia literature, it's interesting that they'll talk a lot about kids who have speech problems. If you look at the apraxia literature, they mention that a lot of these kids have coordination issues. And ultimately, these groups are all talking about the same children. And we're not doing a good job of communicating with each other. So children with verbal apraxia have a classic history, so they tend to be quiet babies. They have limited babbling, so that's one of the first signs. Then they develop, as they get older, an elaborate gestural communication, which really does separate them from the kids who are autistic and not, interacting with their environment. They're really trying to communicate. Their receptive language far exceeds their expressive language, and they tend to be of normal cognition, or I'd argue of even above normal cognition. And the classic apraxia, they make inconsistent errors. So this is different than articulation disorders where the errors are similar again and again and again. And these errors increase with the length of utterance. So these kids are highly unintelligible, and you can imagine that this is very frustrating for the child. And a lot of their behaviors are out of frustration. So how prevalent is it? Well, it was reported in, it was reported in 1997 that it affects less than 1% of the kids, 1 to 2 per 1,000. But then later, 6 to 10% were reported if you actually include for comorbidity. And that actually sounds a little bit high to me, but it was reported to occur in up to 50% of children with autism spectrum disorders. There we go. And actually, if you talk to the FDA, which I did, because my other hat is in rare hematologic disorders, so I've worked with the FDA on orphan diseases, and there are actually funds for orphan diseases. So I approached them saying, well, I think apraxia is a rare disease. Can I get some funding for this? And they were very savvy and started asking me a few questions, and they said, don't those kids with autism have apraxia too? And don't we see it in Down syndrome? And next thing you know, we start doing the numbers, and the definition of an orphan disease means that there's less than 200,000 children affected in the United States. So soon we were way beyond 200,000 kids, and it no longer qualified by FDA's purposes as an orphan disease. So then if you step back and think about over 200,000 kids, no studies, not recognized by pediatricians, this is really unacceptable. Now I give, there it is, some more details for people who are interested in learning more about apraxia. There's a really nice article by Marilyn Egan in Contemporary Pediatrics, The Late Talker, When to Refer. And what's nice about that article is it really gives hardcore signs of when to refer. And it's considered emergent referral if at 18 months you have less than 10 words, or you have less than 50 words, or not stringing 2 words together at age 2. So by the time you're at that 18-month to 2-year range, if you're behind, you really should be getting referred to a speech and language pathologist. So what about risk factors? Well, boys are affected more than girls, but when girls are affected, they tend to be more severe. There is a genetic risk that's been identified for specifically apraxia with the FOXP2 gene, and this is involved in how certain nerves and pathways in the brain develop, and these abnormalities may affect motor coordination, speech and language processing in the brain. Now, since these studies, there have been some other genes that have been identified. There's also some genetic syndromes, like velocardiofacial syndrome, that tends to have more apraxia, and then there's also metabolic associations. And the metabolic associations I find most interesting because we could probably learn a lot about what causes apraxia when we study these diseases that we do understand, like galactosemia. So a child with galactosemia is 180 times more likely to develop childhood apraxia of speech. And some of the studies that actually looked at children with galactosemia through the foundations found that 80% of these kids had CAS. So again, it raises an eyebrow, what's going on with that disease of sugar metabolism that's contributing to the development of childhood apraxia of speech. And then autism. So again, reports of up to 50%, and I think families and practitioners who are dealing with children who have autism understand that there's a component of motor planning issues with these children. Now, a recent paper was published by Schreiberg, who actually published some of the earlier, thank you for pointing that out. Sorry. So Schreiberg et al., and they were the group that said that this is rare and happens in 1 to 2 per 1,000 children. They actually looked at or tried to debunk the hypothesis of CAS associated with autism, and they argue against it in a group of 46 patients that they looked at. And it was a small cohort, but if it's so prevalent, you would have expected them to see it. So I first said, that's interesting. Then I pulled the paper and looked at their methods, and it turns out that they excluded kids who were so in order to get into the study, you had to be over 70% intelligible, and it had to have, at least a 3-word utterance. So they basically excluded all the apraxic kids and then were surprised that they didn't find any. So I would have been much more interested in including the kids who are unintelligible, because that's basically the definition of these children's speech disorder. So, and then it also seems to be higher, more prevalent in Down syndrome. So what do you do if a child is suspected of having CAS? So I think that the first thing that you need to do is you need to get their hearing tested, because you can sound like a child with apraxia if you have hearing loss. And the thing is that you'd be going in a completely different direction, and you need to get that information early on. You don't need to wait until they're 18 months. There are other signs that this kid is not developing, speech or not babbling normally. But the thing is that at least in the United States, none of your assessments will start until you have that hearing test. And gosh, it takes forever to get any of these tests. So start early so that you can march through and get your intervention for free. Getting seen by a speech therapist, you want to find someone who has some understanding of motor planning disorders. Not all speech therapists do. Finding a prompt therapist is even more ideal, but they're sometimes hard to find. And then, like I said, referring so that you can actually access the state-funded early intervention programs, which at the United States is 3, and then you have to go through this whole process all over again with the school system. So another, early introduction of sign language is also really important for these kids who are having poor communication. And I can't say enough about, oops, I'm sorry. I don't know what's happening here. I can't say enough about signingtimes.com. These, they're kind of expensive, but the videos actually can be downloaded on YouTube. And the thing is, it's really easy to watch these videos and get your kids to watch them, and the whole family can learn sign language. If you commit yourself to sign language, the whole family has to learn. So it is just as frustrating for a child if their signs aren't understood by their family members than if their words aren't. So again, it's a commitment, but it's one that is absolutely worthwhile, because you'll learn that these kids have so much language and so much to say. And in our case, when I finally was told by speech therapists that you have to learn sign language. I know you've got a full-time job, and I was so stressed. Within 2 weeks, this kid's signing 5- and 6-word sentences, and we didn't realize, we were told he was retarded, and here he is, he's speaking to us through signs. So it was amazing, and I wish I had started it sooner. So, and then any forms of alternate communication. Some kids with severe dyspraxia have a hard time with sign, so pictures, however you can actually communicate with your child. And what tests for CAS? So there are a number of specific tests for motor planning disorder. The Kaufman speech praxis test is the best well known. So, and this is where you actually need to be an educated parent to advocate for your child, because if you're now in the school system, they won't always do these motor planning tests. And if you have an older child, because the diagnosis has been delayed, they may have mastered single words, but if they say ball, so if you have these certain articulation tests, they're fine. But if you put it in baseball player, it's be, by, boo, and no one can understand what the child is saying. So it can be missed without the appropriate tests. And the thing is if you don't know what to ask for, you're not necessarily going to get it, because the speech therapy is very, very expensive. Okay, so next, now my picture is frozen. Okay, so, there we go. Okay, so we'll just have to look at both of them. So speech therapy is the primary treatment that is recommended for childhood apraxia of speech, and it needs to be aggressive, one-on-one. Folks who have worked with these children understand that group therapy does not work. But the problem is that there's limited evidence for any therapies, including speech therapy for childhood apraxia of speech, and there have been no randomized trials. I was actually pretty surprised about this when people talk about where's the literature when you look at fish oil and vitamin E, when there's very little literature even to support the use of speech therapy. But we know anecdotally that it works. And, but because there's little literature, it also makes it very difficult to get it covered by insurance. So what's interesting is 2008, there was a Cochrane database analysis looking specifically at interactions for CAS. No studies met their criteria. And the review demonstrates a critical lack of well-controlled treatment studies addressing treatment and efficacy for CAS, making it impossible for conclusions to be drawn about which interventions are most effective for treating CAS. So again, we'll remember that as we talk about some other therapies that anecdotally seem to be working. It's working now. So, and then there's also a number of neurologic soft signs that you see commonly with verbal apraxia, which again makes you wonder, this doesn't sound like it's just a speech disorder. So very often the kids will have low muscle tone, particularly in the trunk. They have poor gross and fine motor coordination, so the developmental coordination disorder. Motor planning problems tend to be global. Drooling exceeds what's expected for their normal expectation, their age. Signs of apraxia, not blowing out their candles or blowing bubbles. And then sensory integration and self-regulatory issues. And again, you look at this list and it sounds a lot like the list that you see in kids with autism. Particularly abnormal pain sensation. They also have proprioception and vestibular sensation. And when you start to understand the fact that they're not feeling pain, then some of their crazy behaviors seem to make a lot more sense, because gosh, it's fun to jump off the top of the monkey bars if it doesn't hurt when you land in a pile. So you start to look at this, and, and I started out hearing, that we're dealing with a speech disorder, but then I'm looking at a child who has global abnormalities, and then when I met other families who were dealing with kids with apraxia, everyone's telling the same story, and I thought, my gosh, this sounds so homogeneous that it's starting to sound more like a syndrome. And then the aha moment for me was really this discovery of work by, let me make sure it's up there, work by Ron Sokol and colleagues, who's a pediatric GI doctor who's done a lot of work in vitamin E. And what I realized was that the symptoms, all these odd symptoms that affect different organ systems and different neurologic pathways, overlap the symptoms of vitamin E deficiency. So here we have hyperreflexia. So, the problem with these apraxic, dyspraxic kids is the reflexes are not normal. So they're clumsy, they fall down, and they don't get their arms out. So not only do they fall down, but they fall down on their face. So you end up spending a lot of time in the emergency room unless you just let the lacerations heal on their own, which is what we eventually started doing. I would butterfly at home. Come on. Can you see it? Okay. So cerebellar ataxia, so basically coordination issues. This was actually fascinating. Loss of position sense, vibratory sense, and loss in particular of pain sensation. This is a pathway towards sensory integration dysfunction, and never before had I heard of a mechanism that would explain sensory integration dysfunction. So I was fascinated and excited, particularly about the pain sensation, because when you have a child who doesn't feel pain, that's a very unusual phenomenon in pediatrics. We just don't see that, but gosh, you see it in a lot of apraxic kids, and then you also, I learned, you see it in the children with autism. So, and then you also have muscle weakness, so hypotonia and dysarthria. I doubt that our friend, the GI doctor, could actually differentiate between dysarthria and apraxia, but now we have a mechanism that gives you speech and coordination problems, abnormal sensory integration. I was over the moon because I thought, gosh, could it be so easy as vitamin E? And I was very naive back then, but it certainly makes a huge difference. And if you actually look at these different metabolic and genetic conditions, they're very diverse. So you've got A-beta lipoproteinemia, which is a syndrome that has very, very low cholesterol, chronic liver disease, where you have absorption problems of the vitamin E, other fat malabsorption syndromes like cystic fibrosis, celiac disease, even Crohn's disease are associated with vitamin E, and then this genetic vitamin E deficiency. So it doesn't matter how you got there. Once your body has a low vitamin E bioavailability, you're going to have this constellation of symptoms. And there are many pathways to get there, but ultimately it translates to neurologic complications that, oh my gosh, sound just like this apraxia phenotype. Let's see. So, in search of more information, I actually learned that a lot of families were doing omega-3 fatty acids for apraxia, and there was very little information out there. I read Jacqueline Storti's work that showed that omega-3s improved with, that dyspraxia and apraxia improved with omega-3 fatty acids. And then the Oxford-Durham study was a well-done study in pediatrics that showed that these kids had improvements in dyslexia and dyspraxia with improved reading performance, motor skills, and behavior. So as you look through the literature, there's actually quite a, I'm sorry, thank you. There's quite a lot of literature supporting the use of omega-3 fatty acids in children with neurodevelopmental disorders. Now, this study is particularly interesting because it's an ADHD study, and there are a lot of people using omega-3 fatty acids for ADHD. This was a randomized placebo-controlled trial, so the gold standard. They looked at 75 patients. And this was a negative study, so why is she getting excited about a negative study? Well, because the authors were very smart. So the majority of kids did not improve, but you had a subgroup of kids that remarkably improved with their ADHD symptoms, so much so that the parents were overjoyed. The authors of the paper went back and reviewed the charts of these children, and lo and behold, these were kids who had comorbid neurodevelopmental syndromes, mainly dyspraxia. So it appears that the dyspraxia group is a subgroup that seems to respond well to omega-3 fatty acids. So, and I think that this is part of our problem when we're doing clinical studies, is that like autism is a big diagnosis with lots of different causes and lots of genetic and metabolic reasons. We throw them in the same basket, we give them one intervention, and we expect it to work. We really need to try and separate these kids so that we can identify the right treatment for the right child. And we need biomarkers to help identify the responders, and we need to start clinically phenotyping these children. So more information on omega-3s. There have been a couple of small studies in autism. So improved language skills, decreased hyperactivity. And then this study is interesting here by Alexander Richardson that she showed that there's actually membrane phospholipid abnormalities. So now we're going beyond, gosh, we give omega-3s and we seem to see some clinical benefits, and we're trying to get to, well, what could the mechanism be? And she found these abnormalities in psychiatric and behavior disorders, particularly schizophrenia, dyslexia, and dyspraxia. So very interesting observation. And then, of course, there's been the work by Marilyn Egan, who is a neurodevelopmental pediatrician who wrote The Late Talker in New York. She's amazing, and she's a wealth of knowledge and has been a great support for me over the years. And she had data that showed that, in children with verbal apraxia, so she was seeing these kids and following them closely, you had improvement in speech, attention, and affect when they're put on omega-3 fatty acids. And she presented her data back in 2002 at this omega-3 research conference. And so again, now we're at 2014, and not for lack of trying, it is just not easy to get funding for these sort of studies, even though this question could be answered very easily. And so in addition to her study, there's strong anecdotal data from thousands of families dealing with children with apraxia from Apraxia Support Group that find that using omega-3s help their kids talk. So not everyone could be wrong. So what do we know about vitamin E? So it's a fat-soluble vitamin. It's a potent antioxidant. It's got 8 chemical isoforms. So there's the tocopherols and the tocotrienols. There's alpha, beta, delta, gamma. They are all different, but part of the same family. But it can lead to confusion. Alpha tocopherol is the active vitamin E when you think about vitamin E supplementation. When you go to the health food store, there's 2 types. There's the alpha D and the alpha DL. And the alpha D is the natural form of vitamin E, the one that you want to use. The DL is the synthetic, and it's about half as potent, and there's a lot of problems potentially with using a synthetic vitamin E. You want to stay away from it. Vitamin E is absorbed in the small intestine. That's going to be an important point as we get to some of the GI issues. So gamma tocopherol should be at least 20% of your supplementation, because it turns out with long-term alpha tocopherol supplementation, you create a gamma deficiency, and we don't understand all the implications of a gamma deficiency. It's a potent antioxidant, and you don't want to cause a deficiency. So you have to find the balance. So you need to use a combination of the cocktails. But ultimately, vitamin E protects your polyunsaturated fatty acids from oxidative damage. So there have been a few studies that actually look at vitamin E in autism. It turns out that, shockingly, vitamin E, like many of the antioxidants, are low in children with autism compared to normal controls. And these 2 studies here are more recent, low vitamin E, but also another study that looked at low vitamin E, low glutathione, another important antioxidant with increased lipid peroxidation, which is what's going to happen to your cell membranes and fatty acids when you don't have sufficient antioxidant protection. Okay, so this is your friendly cell membrane. And this is, I've borrowed this from Franz Kuipers, who is a brilliant fatty acid metabolism red cell guy. And you have this double bilayer, and you have this sea of phospholipids and proteins. And depending on how those phospholipids and proteins are made up will affect how messages are passed through the cell membrane. And actually, if you have a lot of trans fats or omega-6s that are inflammatory and you don't have enough omega-3s, your body's going to make do with what's there. They're going to get incorporated into your cell membranes, and you can imagine how the messages are going to get scrambled. And I think that this was actually discussed a little bit by Dana Lake yesterday. Okay, so you've got these phospholipids and proteins that make up your cell membrane, and phospholipids are chains of fatty acids, and these are long chains of carbon. I won't go too much into a biochemistry lesson, but what a polyunsaturated fatty acid is it means that there are these double bonds, these little red lines. It means there's 2 red lines instead of 1. If there's no red lines, it's saturated. And whoops. Now I went backwards. And here are a couple of polyunsaturated fatty acids that may look familiar, DHA, EPA. But one of the problems with those double bonds is that they're incredibly vulnerable to oxidative stress. And what happens when you have oxidative stress is that they get destroyed. So your cell membranes are just going to go to mush. So reactive oxygen species will attack these. Then you end up with increased lipid peroxidation, although the body has an amazing way to heal itself, but you have increased turnover. One of the important roles of vitamin E is to protect your double bonds, your fatty acids, from oxidation. So vitamin E plays a really important role against protecting against peroxidation. And actually, that's why it's in fish oil bottles. It actually increases the shelf life. But from what I've learned, there's also, I believe, some true clinical implications of having vitamin E together with your omega-3. So when you look specifically in the neuronal plasma membranes, you have high turnover of your cell membranes in your brain. And if you have increased oxidative stress, that's going to be even higher. So you can imagine that dietary polyunsaturated fatty acids may have some benefit. And in fact, if you start out with a deficiency and then you're having a challenge, you can get into trouble. And when you think about the American diet, well, I'm not sure if the Canadian diet is much better, but we are certainly low in our omega-3 fatty acids, but I don't think that this is just diet alone. There's more to it. So at any rate, polyunsaturated fatty acids in your cell membranes, will make your cell membranes vulnerable to lipid peroxidation, and early destruction of vitamin E is not available. So this isn't hypothesis, this is fact. And this has significant implications for neurologic sequelae. So and this is actually a nice, okay, but I can start talking again. So this is actually just a nice slide showing potential mechanisms of oxidative stress in autism. And just the basics are this idea of increased pro-oxidants and decreased antioxidants and how the environment should have an effect. And I understand you guys all have a copy of these slides so you can actually look at this more clearly. But to simplify it, really what you have is redox imbalance. So you have increase in your oxidant production and then an antioxidant loss, which oversays, so either you're not taking in enough antioxidants in your diet, they're being consumed, or you actually have problems with production with abnormal enzymes that are going to affect your antioxidant balance. But again, you can see how we end up with a imbalance. And there's probably no single hit because the body has an amazing way to compensate, but when you get multiple hits, you start to see a tipping of this balance. I don't trust these slides anymore. So our hypothesis, just kind of stepping back and looking at all these families who are describing improvements with omega-3s, and then discovering the overlap with vitamin E, and hearing lots of unbelievable reports from families that were trying this, so I tried to gauge what was really going on. First of all, as I said, apraxia is considered to be a speech disorder. So with all these families describing multiple symptoms, we wanted a better idea of how to characterize these kids. So is there a subgroup of children with, that really did have these multiple symptoms? So our hypothesis was that abnormal fatty acid metabolism and vitamin E bioavailability plays a role in verbal apraxia, and that inflammation of the GI tract, either through food allergies or gut gluten sensitivity or inflammation in general, would lead to malabsorption of key nutrients, including fat-soluble vitamins, vitamin E, carnitine, omega-3 fatty acids. So this increased consumption of antioxidants due to inflammation, oxidative stress would contribute to this fatty acid metabolism dysfunction and ultimately neurologic abnormalities. And if this was true, then nutritional interventions may benefit children with verbal apraxia. So we wanted to determine the efficacy of vitamin E and polyunsaturated fatty acids in this group, and as I said, we also wanted to characterize the signs and symptoms of these kids with apraxia. So 187 children participated in the questionnaire. So we posted a questionnaire on a apraxia support group. This is a case series, and the information was collected, either broadcasted via email or people directly contacted me. I received IRB exemption from my institution to collect this data. And celiac panel, fat-soluble vitamins, particularly D and E, were obtained, and carnitine were drawn when blood work was performed. And then kids were taking alpha-tocopherol, D, the natural form, in varied doses of 400 IUs to 3,000 IUs a day, with the majority of families taking 800 IUs a day. And then omega-3s, most of the families were using Nordic Naturals, a combination of EPA and DHA with a ratio of 2.5 to 1. We don't know that that's the best ratio, it's just that is what was available with Nordic Naturals, and that's what seemed to be working with these families who had tried maybe DHA alone, and they were kind of experimenting with their own kids, and then they shared information on what seemed to be working best. So in our results, we had 187 kids who participated. Now, these are children who were diagnosed with verbal apraxia by a medical professional, and of those, over 25% had a diagnosis of autism spectrum disorder. The age range was 2 to 15 years. The median was 4. Most of these kids were under age 5. 80% were boys, which reflects the male predominance. And in our questionnaire, we were seeking information on comorbidities, and information specifically in the presence or absence of a diagnosis of autism, but also other conditions was requested with a yes or no response. It was a pretty simple questionnaire. Not all families, though, reported the presence or lack of these conditions, so the true denominator is unknown, but I'm just reporting the data of the information that we received. So common comorbidities, so autism spectrum disorder was at the top. So, you know, the majority of families who answered the question answered yes, but there were a number of families who actually didn't respond. And that's an interesting other side topic about the children with apraxia, many of whom probably did have an autism diagnosis where they didn't necessarily want the diagnosis. And then I also think the flip side is that there are many kids who are diagnosed with autism who really have severe apraxia. So we really need to better define what these conditions are. Only 8 kids were diagnosed with ADHD, but if you think about the age that we're looking at, most of these kids were under 4. Kids are diagnosed older, and if you talk to anyone who is either a parent of an older child or a professional who is dealing with it, it evolves into ADHD and dyslexia and all these other learning and reading problems, you know, if you can get past the speech issues. And most of us are happy if we get past the speech issues. So a small number of seizure disorders, but a number of other global delay. Phelan-McDermott syndrome, this was an interesting group only because we understand this disease and trying to figure out why would these kids be responding. This is a disorder, genetic disorder that affects glutamate excitotoxicity. And what I learned from trying to read about 22q13- is that it turns out that vitamin E stabilizes the glutamate receptor and decreases excitotoxicity linked to glutamate. So that's one additional possible mechanism that vitamin E may be helping. So, and then there were single cases of all the following, which again was very surprising because I was thinking these kids were all, you know, childhood apraxia of speech, otherwise healthy children. And we had Williams syndrome, chromosomal microdeletions, fetal alcohol syndrome, one diagnosis of complex 1 mitochondrial disorder, Sanfilippo syndrome, and brain tumor. So, and some of these kids were actually diagnosed with their diseases after a CAS diagnosis. So they actually moved along with this diagnosis of apraxia, and then someone did a bigger workup like a MRI and realized, oh my gosh, this kid's got a brain tumor. So again, striking me that the diagnosis of apraxia by itself is not necessarily a benign diagnosis, and you need to look for other things. Because look at, I mean, 187 children, there was a lot of significant comorbidity. And since then, I've actually had some interactions with the Niemann-Pick-C group, and many of those children, and Niemann-Pick is a rare disorder that affects cholesterol, accumulates in the cells, and they end up initially presenting with an apraxia phenotype. But what's different about them is that it's neurodegenerative, so they will continue to degenerate, and eventually someone does more tests and their diagnosis gets picked up. But many of the kids with Niemann-Pick are initially diagnosed with apraxia. Oops. Okay, so other common comorbidities. So, you know, in addition to all these other symptoms that we talked about, GI symptoms were also common when we started asking families about it. And again, the problem is that we don't have a control group, but now we're at least finding if your kid is a kid with GI symptoms and apraxia, it doesn't matter if there are any others because that's what you're dealing with. Allergies were incredibly common, particularly when they had food allergies, they tended to be multiple. Gluten, milk, and peanut were the most common. Many of these families were tied in with allergists because the allergies were a huge component of their condition, and a lot of kids had both allergies and GI symptoms. Sensory integration dysfunction, the majority of family who answered this question answered yes, and particularly high pain tolerance. Again, that was something that struck me with these children because that is a very unique condition. Hypotonia, particularly in the trunk, also very common, and then, you know, dyspraxia, developmental coordination disorder, very, very common. And again, like I said, many families may not necessarily realize that their kid has dyspraxia, particularly when they're younger, and then when they can't tie their shoes or can't ride a bike, they start to realize that there may be something different. But it's often overlooked. So what's interesting, though, in this group is that the majority of children improved. So 97%, 181 families anecdotally reported improvements in speech, babbling, imitation, coordination, less falls, eye contact, behavior, sensory issues, a lot of the issues that Marilyn Egan had seen kids improving with fish oil. But these improvements surpassed those that were expected from speech therapy alone. As far as adverse reactions, we had one boy who experienced a new and tearful, aggressive behavior within 3 days of starting vitamin E. He was taking 400 IUs a day. He had no apparent benefit in speech, although it usually took 3 or 4 days to see a difference. And his therapy was stopped within a week. We don't understand why that was, but that was what they described. And then there were 5 families that described absolutely no benefit, but no side effects. And then there was one family who had a child who had a history of nosebleeds, who had nosebleeds while he was on it. So anytime I hear bleeding, because I think that bleeding is as a possible side effect of vitamin E, you at least include it. But there were no other adverse reactions reported, but there was this phenomenon of increased moodiness and transient aggression that happened with a lot of kids when we started the fish oils. But it was often accompanied with increased speech and babbling and seemed to identify the responders. So depending on how bad it was, if you could wait out the storm, at the end of those 2 weeks, you had a lot of benefit in speech. So, but you were always seeing some benefit. It wasn't all bad. And we kind of termed this the Tasmanian devil effect because that's exactly what they seemed to be. But gosh, they were talking as they were doing it, so, we were happy. So, and then as far as lab results, 26 patients were able to get their docs to order blood. So this is actually the largest blood sample in an apraxia cohort that's ever been described. So of families that got vitamin E, interestingly enough, there were 3 kids who had low vitamin E in their plasma. It's considered a rare finding, so interesting that 3 out of 12 actually had it in our cohort. But a number of kids also started out with high vitamin E levels before they were supplementing. So again, makes me think, well, at least those kids may have a problem getting into the cell membrane if it's there and it's high in their plasma. And then the rest were normal. But what was interesting is that the pretreatment plasma vitamin E levels did not predict who were responders. All of these kids were actually excellent responders to vitamin E, and they fit the clinical phenotype to a T. So we were, again, surprised by this data. When I talked to Marilyn Egan, she had found the same thing with omega-3 fatty acids. So she's been treating kids with apraxia for years and years, and she had initially looked at omega-3 levels in her apraxic kids, and a lot of them were low. But what she found is that she couldn't identify who was going to be a responder and not to fish oil based on those tests, and she ultimately stopped doing it. So what is in your plasma does not necessarily translate to what's in your brain and your muscles, but I still think that it's important to know where you're starting, particularly for these kids who are low, because that's an absolute red flag to look for an explanation. You got to still treat the vitamin E deficiency, which will improve your neurologic consequences, but we really want to do more than just putting on a Band-Aid. So other abnormal lab analyses, very interesting. So the majority of the kids who had blood work done had a carnitine deficiency. So that's actually a striking red flag that suggests metabolic, mitochondrial, not normal, and this was the first time that this was described in an apraxia cohort. Gluten sensitivity, we looked at this because so many of these families were saying, my kid doesn't tolerate wheat. So we actually screened for anti-gluten antibodies, and the majority of the kids were positive for antibodies. So a gluten intolerance, and there's a lot more discussion in the literature now about non-celiac gluten intolerance. So it is a real phenomenon, but these kids, parents are saying they get sick when they eat gluten, and they were right. So then looking at genetic susceptibility, HLA testing, so 100% of the kids who got HLA testing carried a gluten sensitivity HLA. So 12 boys, 6 who had DQ1, which is an HLA associated with gluten sensitivity and neurologic complications, and there's been publications by the group in London. 4 kids had DQ2 and 1 had DQ8, which is the typical HLA celiac HLAs. And then 1 boy who had both DQ2 and DQ1 was African American, and apparently I'd been told that African Americans don't get celiac disease, which is absolutely untrue. It's just that the gene is less prevalent in that population. So, but it is a common haplotype in Caucasians, particularly of European descent. The frequency is 8 to 20%. So the fact that we found 100%, even though our sample size is small, certainly raises an eyebrow. So could HLA biomarker be a biomarker for patients who are responsive to gluten-free diet? Maybe, and this is something that's worth considering, but certainly when you're trying to tease things out for your child, it provides more information. Vitamin D deficiency, also very common, 6 out of 8 kids, and this is common in the normal population as well, but all the kids were associated with a HLA-positive celiac variant and gluten sensitivity. And 2 of these kids actually had early evidence of rickets, which is kind of shocking, so increased alk-phos or X-ray findings of rickets. So the fat-soluble vitamin issues can be significant. So the other thing that was interesting in our observation was a common finding of fat malabsorption among these kids. Now, if you talk to the families, they describe a lot of diarrhea and steatorrhea and smelly stools, and usually that's a red flag for fat malabsorption, which is also an uncommon finding in pediatric practice. If you talk to most pediatricians, they don't know much about fat malabsorption, and you really have to go and talk to a GI doc. So we had 12 kids who were screened by fecal fat tests. 9 out of the 12 had spot tests that were abnormal. Now, that's not an ideal test. It can miss. In really 72-hour fecal collection, which is lots of fun, is the best way to identify a fat malabsorption, but you can start with a simple stool test. So this suggests some sort of fat malabsorption syndrome. So in all 12 of these boys were gluten sensitive. 5 of them went on to get biopsied because there was concern about celiac disease, particularly with the HLA association, and none of their biopsies were normal. So again, small numbers, but gosh, these kids have got GI problems, although we already knew that before we had the evidence. So lymphoid hyperplasia was present in 4. We don't know if that's a normal variant versus true pathology, but it seems to be seen a lot in the kids with autism when they do get scoped. Gross inflammation in the terminal ileum, not Crohn's, but Crohn's-like, was found in 3 out of the 5 of the children. Villus atrophy was found in 1 out of 5, not consistent with celiac disease, but it was still there. And then gastritis, inflammation of the proximal small bowel, moderate to severe jejunal intestinal lymphangiectasia was found in 1 patient. Oh gosh, did you really get stuck again? Wait, okay. So, and then low cholesterol. This was mentioned yesterday in Dana Lake's talk. So this also seems to be found in this apraxia phenotype. So again, small numbers, but 3 out of the 4 boys screened had very low cholesterol. Low cholesterol meaning less than 100. Etiology is unknown, but this can be a consequence of fat malabsorption syndrome. But we also know that altered cholesterol metabolism occurs in several conditions of autism, particularly Smith-Lemli-Opus syndrome, and in Niemann-Pick as well. So it does, again, raise an eyebrow, and there may be several paths to getting to low cholesterol, but gosh, cholesterol is so important to the developing brain. If it's low, it may actually have some consequences. So, and also, as I was mentioning Niemann-Pick earlier, that there was a new cholesterol vitamin E transporter that was recently found in the gut called Niemann-Pick C1 like 1. And it's interesting because it means that there's some sort of relationship between cholesterol and vitamin E that may not necessarily be well characterized yet. But in the Niemann-Pick story, they've actually found that vitamin E will reverse the Niemann-Pick C phenotype in the mouse model. So there's a lot of excitement in the Niemann-Pick world about vitamin E, which again comes back to, again, it's not childhood apraxia of speech, but these kids are presenting with similar symptoms that I've become very interested in following what they're doing. So safety issues, this is something that's important to all of us, particularly when we're talking about interventions that may not necessarily be recommended by our pediatrician and that there's not controlled studies to show that they do or don't work. So limited information, but we do know that omega-3 fatty acids are safe in children because there's a lot of data. They use it in inflammatory bowel disease and they use it in high doses. But it turns out that vitamin E is also safe across a broad range of doses. So the upper safety limit has been listed at 1,500 IUs a day, but that is not based on any literature. They basically did a study on rats, and they gave them vitamin E until they saw an effect on vitamin K, and then they wanted a 30-fold cushion, and they decided this is the upper tolerable limit. And then in order to figure out the upper tolerable limit from children, small bodies, let's cut it in half or in a third. So there really isn't a lot of science behind that. So what do we know about vitamin E? Well, there have been no reports of overdose in the literature, but it does antagonize vitamin K. So I think that, just trying to understand your biochemistry, that's important because bleeding is a potential adverse effect. And the thing is that if you're dealing with a bunch of kids who have a fat malabsorption syndrome that you may not really understand well, they're low in all the fat-soluble vitamins, including vitamin K. Giving them a high-dose supplement when vitamin K is low could potentially have risks, although we haven't had any reports of adverse events. It's theoretic, but I feel like, we have to be careful. But I think the important message here is that treatment for neurologic sequelae of vitamin E deficiency is actually, it's 100 to 300 milligrams per kilo per day. So that far exceeds the upper tolerable limit, and if you do not treat a child who has a known vitamin E deficiency, it's considered malpractice because these neurologic symptoms become irreversible over time, but are rapidly reversible if you treat right away. And rapidly reversible like within the first couple of days. So again, that becomes an issue when at least some of these kids may have a true deficiency and we may not be doing anything about it. And a lot of my safety information came from Marette Traber, who is an amazing PhD out of Linus Pauling Institute, who's really the vitamin E expert in the United States, who's just been a wealth of information for us. So there's a number of limitations of the data. This is not a controlled study. There were different doses and preparations of supplements used, subjective improvement based on parental report with all the limitations that come with it. But I want to point out that this was an unfunded case series because we really needed to start somewhere. And every important discovery starts with a single observation. I think that what we have demonstrated is that there's enough anecdotal data to show that, gosh, there appears to be this subgroup of kids with apraxia, and they appear to be responding well to nutritional interventions. We should be looking at this more closely, but certainly it's not going to go anywhere until we have controlled trials using validated and reliable outcome measures. So the ASHA position on CAS. So we know that apraxia can be associated with, have a neurologic etiology, stroke and trauma, or primary or secondary as a sign of a complex neuro behavior disorder, but CAS, childhood apraxia speech, is defined as an idiopathic neurogenic speech sound disorder. It's a speech disorder. So, but when you start to look at these kids, really, it sounds like it's an uncharacterized uncharacterized syndrome that affects their bodies globally. And what we called it was a syndrome of allergy, apraxia, and malabsorption, really trying to encompass all the symptoms that these children have. You've got the apraxia, the allergic phenotype, which involves not just food sensitivities, but they seem to have a lot of environmental sensitivities. Gluten sensitivity is common. And then the GI symptoms, which translates to nutritional deficiencies and these symptoms of vitamin E deficiency. And then autism spectrum disorder appear to be variable. So there's certainly kids with apraxia who do not meet the qualifications of autism, but they have there's a huge overlap. And again, when you start to think about that spectrum, I think it's somewhere on the spectrum. So common neurologic soft signs, again, arguing against it's just a speech disorder. These kids have limb dyspraxia, coordination problems, low muscle tone, and then the sensory integration dysfunction, as we mentioned. And then in addition to that, they have these common nutritional and metabolic deficiencies. So most commonly carnitine deficiency, fat-soluble vitamin deficiencies. But what was interesting is that if a deficiency was identified, rarely were they in isolation, and no two kids were alike, which makes it very difficult to come up with a one-stop shopping, because you really have to individualize your therapy based on the children. And I have to say that, it does concern me that so many of these kids had carnitine deficiency, because you really need carnitine to properly process long-chain fatty acids. So, so an explanation for someone who may not respond well to fish oil if they've got low carnitine and they're not being on carnitine is a possibility. And a lot of families are just supplementing without actually doing more evaluation. So, if you're giving a fish oil in a situation where you've got increased oxidative stress and you're not processing it, you're going to actually worsen your lipid peroxidation. So I think that these kids really need to be worked up more carefully. So what labs should be checked in a child with CAS? Well, I'm pleased to say that this looks a lot like Dana Lake's list of labs, and we didn't check with each other before we did this. So you get a lot of information from basic labs, like a comprehensive metabolic panel and a complete blood count that's going to tell you if the kid is anemic, and it's going to lead you down to the B12 folate deficiency versus iron deficiency. Looking for fat-soluble vitamins is also important, because, gosh, if they're D deficient, you can treat that. Getting a plasma vitamin K is pretty useless because it just reflects their last meal, but there is a test that the GI doctors use called PIVKA2. It's protein-induced in vitamin K absence. It's a very sensitive test for vitamin K deficiency, and if you can get it done, it's nice to know, because then absolutely wouldn't want to start supplementing with vitamin E without vitamin K. And then, as I mentioned, carnitine, getting a cholesterol panel, pretty easy. And then the celiac panel, because again, it's not necessarily going to tell you whether it's celiac disease, and if you decide if it's positive to go on for biopsy, that's a different discussion, but at least you know that you have a child that is gluten sensitive. The problem is that if they test positive and they don't get biopsied, I mean, some of these kids who test positive may have true celiac disease, and you probably do want that information, because that's not going to change, whereas some of these sensitivities may improve over time as the child improves. Additional labs, so looking at iron, because iron deficiency is bad for developing brain as well, and then simple stool studies to give you an idea of whether there's fat malabsorption. Now, this is sort of the next tier, and again, Dana actually put it on her next tier, looking at CK levels, plasma amino acids, organic acids, and I think if you're getting to that point and you really suspect a metabolic problem, that you should have some help from a metabolic specialist, because this is beyond most of what pediatricians can handle. And then, of course, find yourself a good allergist if your kid seems to be, allergic, because RAS testing it's not always obvious what they're reacting to, and some of these tests can actually provide some guidance. So I'm going to take a minute to spend a little time talking about urine porphyrins. It is not on my list of tests to get, but I think it's kind of underappreciated, the information that we might be getting from this. So what is it? It's metabolites of heme synthesis, and this is bringing me back, as you know, I'm a sickle cell researcher, so I can actually talk to my hematology friends about this. It gets incorporated into hemoglobin in the red cell, but it is also an important component in cytochrome P450, which is important for liver detoxification. And I think that that's the point of this is a detoxification pathway. So it has been recorded as abnormal or elevated in 3 continents. So the levels are high, not high enough to suggest an inherited porphyria, but they're not normal. And this has been identified in France, in the US, and in Australia. Oops. And at the bottom there is the lab in France that actually runs this test. It's a pretty easy urine test. So what are the symptoms of porphyria? So having high heme precursors in your urine. And actually, this heme metabolism actually is a mitochondrial process, so it gives you a hint at some mitochondrial dysfunction. Now, some of you have heard of the madness of King George, so he did have an inherited porphyria. So you've got the inherited, but you also have the acquired toxin-induced condition. And what's interesting is in Turkey, many years ago, there was a porphyria epidemic. And what happened is that they sprayed the wheat with some pesticide that wasn't supposed to get into the food supply, and oops. So now it's distributed, and all these people died. And it turns out that they had porphyria. And of the women who survived, there was a number of the women whose babies died after they went to get pregnant. So again, you know, their detoxification system was set off balance. So what kind of symptoms do you see with porphyria? Well, it's interesting because you get severe episodic abdominal pain, vomiting, diarrhea, constipation, neurologic symptoms that include weakness and motor planning problems, always looking for those motor planning problems, psychiatric and behavior problems, and liver function abnormalities are common. And the thing is with porphyria is you kind of have a waxing and waning of your behavior. So one day you seem better and the next day you're not, and it depends on what your exposures are. So I approached this group that had a lot of data on children, and it turns out that they had information on 10 children who had childhood apraxia of speech. And abnormal high levels were found in 90% of those kids. So in one case report, over 2.5 times the upper limit of normal during an acute regression, and the urine normalized after recovery. So a little background on this, 3% of the population has a genetic variance in genes that code for the enzymes in heme synthesis. And this genetic predisposition is likely underestimated, but you know, you can actually insert glutathione, methylation enzymes, you know, I mean, so this is just to give you an idea of all these different pathways that we can have genetic variants that may make us more vulnerable, where you end up having the perfect storm, where you have a silent mutation that suddenly becomes symptomatic as toxic exposures accumulate, just like in Turkey. They were all fine until, you know, someone gave them a bunch of pesticides. So what we know about children with autism is that methylation abnormalities will create a vulnerability. And I can tell you in the, you know, I have one case of, we've looked at methylation abnormalities in the apraxia, and certainly it looks like all the methylation reports of Jill James in glutathione and all that sulfuration methylation pathways. So we've got evidence in the literature of oxidative stress and impaired methylation in kids with autism. Jill James has done amazing work in this, but there have also been others, including Jung Soo, who is one of my collaborators over in Oakland Children's Hospital. So they've also found that glutathione levels, which are potent antioxidant, is low, and then as we mentioned, other antioxidants like vitamin E, low in kids with autism compared to their normal controls. And there's a growing number of papers that talk about mitochondrial dysfunction as well in autism, which I think is the common denominator for oxidative stress. So I think I'm getting close to my time, right? How much time do I have? 15, okay. So that's fine. So this is actually a model of the clinical SAAM phenotype, where you see that genetic susceptibility is there, but it doesn't necessarily translate to disease. And I think this is a really important concept, not just for autism, but for so many diseases where you've got SNPs and genetic protection and variability. You have this balance of protective factors, you breastfed, vaginal delivery, your genetics are really, really strong, compared to these risk factors. And it may take more than one risk factor to upset the balance. But as we accumulate sort of this barrel of factors, the barrel starts to fill up, you're going to start tipping that balance and push down these downstream effects that lead to allergy, nutritional deficiencies, and the downstream effects that are ultimately neurological dysfunction. So to borrow from Martha Herbert, who says that she believes that autism is a disease that affects the brain and not a disease of the brain, if you look at this pathway, apraxia is also a disease that affects the brain. And there are so many areas that we can actually hit. You know, no single mechanism is occurring in isolation, and we need to really start hitting multiple mechanisms to get the best recovery. So can diet help? So there are no well-controlled trials that say yes, but if you talk to families, absolutely. If you think about a kid who has an allergy, certainly if you eliminate that allergy, that in itself is going to decrease inflammation, and any doctor will agree with you. There's a high prevalence of anti-gliadin antibodies in our apraxia cohort, so it appears to be a problem with those children. So this frequency was 80% compared to about a 12% frequency in the general population, and then 100% HLA. So again, suspect. Benefits of gluten-free diet have been described in autism, but conflicting results in the studies have been very small. Now, what's interesting, and again, the research is taking a new turn, different diets create different gut microflora. And some of you have probably heard about the gut microbiota. It's kind of the hot topic in science now. And it turns out that this paper was just published in Nature that shows that the human gut microbiome rapidly changes with alterations in diet. And so the investigators were assuming that it would take months or years to change your gut microbiome because it does seem sort of set. But if you change your diet, it starts to change within hours. So if you think about this, and then you think about diets in the autism world, then gosh, as we learn more and more about the gut microbiome, then these diets may be actually having some impact on the gut microbiome. What sort of diets? I'm not going to go through this. Dana did a nice job yesterday. Unfortunately, there's no one diet that works for everyone. You really need to understand their biochemistry to know which one works for you. And there's very little data to support any benefits of diets. But that also means that there's no data to support that they don't work. So if your child is getting better with diet, then do what's right for your child. And actually, you know, Julie Matthews has a really nice summary in her Autism Diets, the First Step to Biomedical Intervention in Autism Recovery, explaining which diets and why and which child it might work best for. And I found it very, very easy reading. So is this a celiac variant? Well, this is kind of where I started, you know, 9 years ago, thinking that this was celiac disease because it was the closest thing that I knew of that had overlapping symptoms. But it is not celiac disease by any classic definition, and if it was celiac, then going gluten-free would make everything go away, and that's not the case. But some overlap in symptoms: fat-soluble vitamin deficiencies, carnitine deficiency, neurological symptoms, GI symptoms. Clearly, gluten sensitivity seems to be a component of this apraxia phenotype. Could increased anti-gliadin antibodies be a biomarker for increased gut permeability? Maybe. These kids seem to have multiple allergies, so that would explain it. And then maybe it could be a useful biomarker. And then, as I mentioned, you know, avoiding offending allergic foods will decrease inflammation. But a little more on celiac disease. Celiac disease is rising, just like autism and apraxia. But this is an interesting case report because they found that celiac disease presenting as autism. So there's this child who actually had a diagnosis of autism by a autism center, and it was ADOS and all that stuff. And then with his GI symptoms, he eventually got diagnosed with celiac disease, and they put him on a gluten-free diet, and his autistic features melted away. So it's interesting because, I mean, you'd be lucky if gluten-free diet is all you needed to do, but gosh, it really does seem to have some effect, and there are kids out there where that's all they needed to do. So that's why I think getting that celiac workup is important. And then to mention that there's a threefold increased risk of autism spectrum disorders with a maternal history of celiac disease. So gosh, is genetic susceptibility for gluten sensitivity a novel risk factor for autism? Possibly. It's certainly easy to screen. The reviewers, when I actually suggested that, I thought they liked genetics. Let's try this one. And the response I got is that there was no evidence that there were more GI symptoms in kids with autism, so your hypothesis has no merit. I certainly believe that the relationship between gluten sensitivity and autism has not been sufficiently explored. So let's talk about that GI prevalence. So this important consensus statement, because at least it got people talking about it, said that there was an absence of high-quality clinical research data supporting an increased risk of GI disorders in ASD. And that children with ASD should be treated to have as many GI disorders as their non-ASD peers. Unfortunately, what the general pediatrician will say is that those GI symptoms don't exist. And that was problematic, even though they were really trying to bring attention to the fact that if the kid's got constipation, refer them to a GI doctor and do what you would do for any other child. But since then, this meta-analysis, which is very exciting, done by Barbara McLahan at my university, showed that the increased prevalence of GI symptoms in autism versus controls without a doubt. So this really answered the question. The odds ratio is over 4-fold, and they have a lot of diarrhea, constipation, abdominal pain, and a lot more than the normal kids. But you guys all knew that. And sometimes the experts are wrong. So looking at some of Kriegsman's work, so he actually published the endoscopy reports of these kids. So these are children who clearly had GI problems because they went to a GI doctor. And he found a lot of diarrhea. The majority of the kids had diarrhea. A lot of them had abdominal pain, but constipation was also a problem. And actually, if you talk to these families, it's also often alternating constipation versus diarrhea, which is very frustrating. A lot of these kids had lymphonodular hyperplasia. We don't know what that means. But there was colonic and small bowel inflammation in the majority of the kids that he scoped. And you had active colitis in 69%, and then ileal inflammation in another third of these patients. Then you look at another recent study that found a unique gene expression profile in children with autism and ileocolitis compared to normal controls and actually a group of children with inflammatory bowel disease. So they looked at Crohn's and ulcerative colitis, and that unique gene expression has been identified in Crohn's disease and these other inflammatory bowel diseases. So the kids with autism formed their own little pattern, which really does suggest that this is something different. But there was a little bit of overlap, which gives it this, it's Crohn's-like, but really not Crohn's. And because it is not Crohn's, it's nothing that we've really seen before, no one knows how to treat it, which is ultimately why they're not getting treated. And this is why we need more research, because that needs to change. So I think that the gut microbiome is an exciting area for future research. About 90% of your cells are bacterial. My son thinks that's really gross, especially since he doesn't like bacteria and wants to wash his hands more. So, I love this saying here is, you're not what you eat, but you are what eats what you eat. So, gosh, now we need to worry not only about our own metabolomic processes, but now we need to worry about the metabolites of the bugs when we feed them. So it gets very, very complicated. So what do we know about abnormal gut flora? So the gut microbiome has been linked to obesity, anxiety, big problem with kids with ADHD, big problem with kids with autism, and also the apraxia phenotype, accelerated atherosclerosis. These are making news in big, high-impact scientific journals, and a number of other diseases. What about small bowel bacterial overgrowth? What is that? I'd never heard of that before either, but it means bugs in the wrong place. So you have a lot of bacteria in your large intestine. If it ends up in your small intestine, it doesn't belong there. So even good bugs in the wrong place can cause problems. So if you have small intestinal bacterial overgrowth, SIBO, this is going to cause a malabsorption syndrome because you're competing for your nutrition. Multiple nutritional deficiencies. Now, these kids would respond to gluten-free, casein-free diet, even if they weren't gluten intolerant, because you're limiting the food for the buggers. They'd also respond to a specific carbohydrate diet. There's a number of risk factors: celiac disease, immune dysregulation, antibiotic use, and gosh, if you've never had an antibiotic in your life, but you eat meat that isn't grass-fed, we've all been exposed to antibiotics. Steroid bursts. A lot of these kids have got reflux, so they're put on proton pump inhibitors, which decreases the acid and allows the buggers to grow in their small intestine. Then you've got SIBO, then subsequent nutritional deficiencies as a result, and then you have this vicious cycle. And what's interesting is that SIBO is associated with B12 deficiency. So you can start out with, my methylation pathway is just fine and healthy. You get SIBO, this triggers a B12 deficiency, which ultimately pushes towards a methylation defect that impacts your downstream glutathione. Now your glutathione levels are dropping. This is going to trigger a secondary vulnerability that you weren't born with to environmental toxins. So this really isn't science fiction, it's biochemistry. So, and then briefly, I just want to talk about intestinal lymphangiectasia, because it's another term that I'd never heard of before, and I think I just learned to say it properly more recently. This is one of likely many paths to the apraxia phenotype, but is absolutely one feasible explanation for apraxia. It is a rare disorder, at least it's reported to be rare, so less than 200,000, like less than 1,000 have been reported. But whoever checks, nobody checks. And what is it associated with? Matt, what you end up having is your lymphatics are abnormal. They dump all their protein and their contents and their gamma globulins and their white cells into your gut, and you end up with a number of problems. Malabsorption of fat. You can't absorb fat-soluble vitamins because your lymphatics are actually dumping instead of taking in. Protein loss, malnutrition, nutritional deficiencies, poor growth, vulnerability to small bowel bacterial overgrowth, because now you've got a constant feeding of the bacteria if your small intestine is affected. You lose your gamma globulins, so all of a sudden you've got an immune deficiency. So this may explain why some kids actually respond to IVIG. And then diarrhea and statorrhea, but I can tell you that a lot of these kids will also have constipation in between. And the thing is, it is reported to live with neurologic symptoms of vitamin E deficiency or those symptoms that overlap those in an apraxia phenotype. And this is what it looks like. So you can tell this is a normal, healthy, small intestine, jejunum, and this is intestinal lymphangiectasia. All these white spots, you can imagine there's no place to absorb food here. And there's bacteria living off of all the food that they're getting that's dumping out instead of being absorbed. And I know this well because this is actually my son's pill cam. So the problem is that on endoscopy, this would be missed. So because it is so far down in the small intestine, but you have a child who has all these symptoms of nutritional deficiencies, it's got to be the gut. That's what Hippocrates would say. And it is. So with PillCam, we now have the ability to actually see inflammation that may not necessarily be obvious even on endoscopy. So then, I know I'm running out of time, so neuroinflammation is another piece that's been discussed, and certainly the Vargas paper has demonstrated that there are increased cytokines in the brains of people with autism. So inflammation is definitely a component, and now the accumulating data that shows that this gut-brain interaction, dysbiosis, and neuroinflammation is a reality, and it's starting to show up in Nature papers, but it's just not. We need to get those people together with the autism people so we can all be on the same page. So here's the problem with apraxia. Okay, you've seen this before. It's the elephant and the 6 blind men. So here you have the speech therapist, who is adamant that this is just a speech disorder. They're a member of ASHA. Over here, you have the occupational therapist who's working really hard with this elephant that has developmental coordination disorder, but doesn't really know the speech therapist. And then rarely do you have anyone who asks any questions over here, but if he did, he'd find out this elephant has a lot of constipation, diarrhea, abdominal pain, and gosh, I wouldn't be standing back there. And then the guy up here is saying, gosh, you know what? He seems to, have phonophobia, and the noises seem to be much louder than they should be. They're all talking about the same elephant, but no one's talking to each other, and that is part of the problem. So what we need is a multidisciplinary approach. This is a complex disorder. This isn't just a speech disorder. Autism isn't a disorder of the brain. Multi-organ systems are affected, and there's data in the literature to support that. The brain is affected, but it's motor and sensory. The muscle, gut, immune system, hematologic, metabolic, skin and lungs, and all these allergic kids. So we got to get everyone at the table because we all have different strengths, and if we actually share our information, I think we can come up with a solution. So we need more than the developmental pediatricians, but I also want the biochemists sitting at this table because I really think that they're going to be the ones who are going to be able to help us sort this out. They've certainly been the ones who have helped me most. So what else can be done? Again, quick list. We've talked about probiotics. They're good for your microbiome. Beautiful paper in pediatrics that shows that it decreases infection, so I'm not sure why everyone's not using them in the wintertime. Avoid processed foods. These kids have problems detoxifying, so you want to avoid their triggers. Give them the cleanest environment they possibly can have, and I think that this is a message that you hear from so many people. Two books that actually helped me a lot, and I realized, oh my gosh, there's other MDs that think like me. It was kind of scary. Changing the Course of Autism by Byron Jepson, and then Martha Herbert, I'm a big fan, The Autism Revolution, that really explains this as a multi-organ system disease, and then they reference the literature. So there is quite a bit in the literature if you look. So, and for those of you who have an apraxic child or work with children, talking to families, these regressions are very, very common. And again, it sounds mitochondrial or metabolic when you talk about kids who regress and then get better. So if you have a child with apraxia that is acutely regressing, you have to look for the cause. So if they started on supplements and they got better and you stop, they're going to go back to where they were before. So you got to look at, have you missed doses? Is the babysitter or dad, sorry dad, but dad always seems to forget. Changing the brand, sometimes the potency is different. And then illness, this is a big deal. So again, making me think that there's a mitochondrial component because who else loses speech and coordination when they get a fever? But the concerning thing from all this feedback from families with apraxia is that a number of these kids have actually gotten hypoglycemic with their stomach flus and clinically hypoglycemic. And the thing is low sugar is bad for your brain. You don't want that to happen. So if you have a kid and you're hearing that they're getting a little bit lethargic and everything, I would lower my threshold to get that kid evaluated to make sure that they're not dropping their sugar. And again, suggest that there's some sort of metabolic component to this. And then, of course, what you do with the fish oil. Oxidized fish oil is worse than no fish oil at all. It's a stress on the system. And if you leave it out, it gets exposed to the heat. So people who are trying to mix it and hide it and things, don't cook it in anything because you've lost all the benefits. And then if they have an allergic trigger, if they're an allergic kid and they ate something that they're allergic to, they're having an inflammatory process, you're lucky enough if hives show up so you know, gosh, this is allergic. But often that'll be associated with speech and coordination. I have to say, as a pediatrician, I found it so hard to believe that this was actually happening, but so many families were telling the same story, and gosh, I was seeing it myself. So, and then weaning of any anti-inflammatory medication. So if your kid's on asthma medication and doing well, and you start to wean it, and all of a sudden their apraxia starts getting worse, then that asthma medicine may have been doing more than just treating the asthma. So, my gosh, I'm so confused. Fish oil, olive oil, turmoil. So I'm hoping that, I'll clarify some of the confusion. So everyone's heard DHA and EPA. You really need a combination of both for the kids with apraxia. If you're going to use vitamin E, you want to use D, the natural form, not the DL. You need a component of gamma, and you need vitamin K to protect against the bleeding. You want to use reliable, high-quality brands. Keep the omegas away from heat. I do need to give a disclosure. I am the inventor for the apraxia formula. It happens to have all those ingredients that we talked about. It is licensed by Pharma Omega, and the patent is owned by UCSF Children's Hospital, Oakland. Any combination of high-quality supplements is exactly what we did. I mean, I made this in my kitchen, and then we got a product. I do not make any personal endorsements for any specific brand, but if someone actually has a family member with apraxia, absolutely fish oil and vitamin E is a safe intervention to try because if it works, it's often miraculous and life-altering. So in conclusion, abnormal vitamin E and fatty acid metabolism appears to be happening in verbal apraxia, and this may contribute to this neurologic dysfunction. The exact mechanism is unknown. It responds to safe nutritional interventions. And now we're getting data that shows that vitamin E levels are actually low in kids with autism, in addition to many other antioxidants. Carnitine deficiency and gluten sensitivity are very common in these kids and absolutely should be screened based on we have the largest cohort of apraxic kids that's ever been published. So we're finding that there are these comorbidities that we can treat, so we probably should address them. Verbal apraxia warrants a much more comprehensive metabolic workup than what's current standard practice, which is really basically no workup. And it's not like the doctors don't want to help you, they just don't know what to do. And that's why I published our case series, because I knew that it wasn't my highest quality science, but I wanted families to have something to bring to their pediatrician. And what we describe as a novel syndrome of allergy, apraxia, and malabsorption. But ultimately, no recommendations for nutritional approaches, I'm wearing my doctor hat now, can be made for apraxia until these observations are validated through controlled clinical trials. And I'm currently seeking funding, but I haven't had any luck in 10 years because nutritional interventions are just not exciting at the NIH level. And the thing is that, the NIH funding they're broke. So it's really hard to get any studies funded. But neurologic complications of vitamin E deficiency become irreversible over time, but they're rapidly treatable early on. So the clock is ticking for these kids, which is why I'm standing here before you. I mean, our kids don't have 10 years to wait for the clinical trial, and especially given the NIH funding crisis. And I realize now that I hadn't done what I did years ago, my son would be irreversibly neurologically damaged. So what about the future? Nutritional considerations absolutely deserve more attention. Nutrition should not be considered alternative medicine. That's ridiculous. Good nutrition should be mainstream, but I think that may change with all this gut microbiome stuff, and we realize that diet is affecting the microbiome. We need research. We need to identify the clinical phenotypes. We need metabolic profiling so we can look at these kids' biochemistry, identify treatable conditions, and then individualize their therapy. So what I leave you with is a call to arms, and I say call to arms because we are at battle. I want to arm you with information and with hope that these kids can get better, but we have to be advocates for our kids. And I don't know what it's like in Canada, but you really have to fight for resources for your children. And the thing is that no amount of speech therapy will help a kid who has severe vitamin E deficiency issues, but the thing is once you start treating it, you need that speech therapist to actually catch him up and bring him to normal. So I looked at the CDC website before I came here, and the new numbers are 1 in 42 boys, 1 in 189 girls. So if you look, the numbers just keep on rising. I mean, this is scary. And then if you think about apraxia affecting over 200,000 kids and no clinical studies, this is a neglected disorder and an epidemic. And we really need to do something that goes beyond just this room. So for those who want an update, this is my true inspiration for this apraxia journal, why a ER doc is even talking about a developmental disorder. He was at an early age diagnosed with severe apraxia. He was nonverbal, and we all learned sign language. He also was dyspraxic. He was the first of the case series. He had sensory integration dysfunction, no pain sensation, hypotonia, bad reflux, fat malabsorption, and a number of GI symptoms that kind of developed over time. I didn't even realize he was a gut kid because we were all focused on the fact that he couldn't talk. And then multiple nutritional deficiencies and so many diagnoses, too many for one child. He doesn't have 20 diagnoses. He has one syndrome that actually causes this cascade effect that ultimately caused his clinical phenotype. But what's interesting is that aha moment of the overlap with vitamin E. When we started him with vitamin E, he was released within 4 months from speech therapy and occupational therapy. And we titrated to fairly high doses, which higher than I will even admit here, because it needs to be overseen by someone who understands the metabolic processes. But his speech, his coordination, normalized right in front of our eyes. I mean, it was miraculous. It's nothing short of miraculous, which is why I'm standing here. He developed pain sensation, which he wasn't very happy about, but I was thrilled. He's like, "Why is mommy smiling? I'm in pain." And at the time of this photo, this is an old photo, he was a near normal 5-year-old, but he has significant neuroregressions and a return of the apraxia phenotype if supplements are skipped, Dad. And with illnesses and fever, again, suggesting that there's something mitochondrial and metabolic that we don't quite understand yet, with allergic reactions. So anything inflammatory causes a worsening of the phenotype. And actually, every spring with his seasonal allergies, we know that his speech and coordination is going to take a hit, but it's okay because it gets better. And also high-carb meals, so tying in the gut microbiome. So there isn't any one thing. It's incredibly complicated. And I can't say that there's any one thing that we did that recovered him. But he was subsequently diagnosed in 2013 with intestinal lymphangiectasia on video pill cam. It took us that long. I mean, I've been working at this since 2004. You know, and this is a GI disorder that's associated with fat malabsorption and malabsorption of omega-3 fatty acids, and all these nutritional deficiencies, and all these symptoms that he has can be linked back to his gut. So he's now a beautiful 11-year-old. He does have ADHD and dyslexia, and like I said, most of these kids will morph into ADHD and dyslexia, and I can handle that. He is intellectually gifted, and he won't stop talking. I mean, I love my daughter's comment, "Mommy, be careful what you wish for." He has a lot to say, and he says it clearly. In fact, he wanted to come with me. And our focus today is on his gut issues. But we do have an incredible recovery story, and I believe that every family who has a child who has this condition should have the same recovery story, so we can minimize the misery and misfortune that comes with the diagnosis of apraxia and dyspraxia. Thank you. And then just a quick appreciation to all who's helped me on this journey. Marilyn Egan, who's amazing, and an unbelievable reference on apraxia. And then if you notice, they're all PhDs, my very smart biochemistry friends. People from Children's Oakland who supported me through this by explaining what I was seeing clinically. Franz Kuipers, Bruce Ames, Jung Soo, and then Ken Martin, the very smart radiologist who recognized the symptoms of vitamin E deficiency. And then Marat Traber for sharing all her information over at Linus Pauling, even though she didn't know me from Adam, but she's gotten to know me over the years. Thank you so much for your time.